I think there's still a few trickling back from afternoon tea, but that's all good. So, last session of the afternoon, always leave the last till best, the best till last. It's definitely the last session, isn't it? I'm fading. So we're going to start off with a presentation. It's a little bit different. So Dr. Yude Jayakandran, that'll do, is a HMO working at Bendigo Health. She's passionate about rural health, having completed a medical school placements and internships in Bendigo and surrounds since 2019. Now, although you can't be here in person, she has actually inserted herself into the presentation and will be presenting virtually in a slide presentation. Emma is here to make sure it runs smoothly and to answer all of your hard questions. So, thank you. Jo.
Hi everyone, thank you for joining me this afternoon. My name is Yudi, I'm one of the HMOs at Bendigo Health, and today I'll be talking through our study, SNORE, which is a snapshot number of obstructive sleep apnea patients in a regional environment. And this is a really exciting study that we've been doing over the last few months. So what is OSA? OSA is a medical condition where the soft tissue in your upper airway can either partially or completely collapse during your sleep, and this can lead to reduced oxygen saturations and eventually leading to arousal from sleep, ultimately leading to very poor and interrupted sleep throughout the night. However, OSA can be quite sinister as it has many different ways of impacting your physiological systems in your body, leading to other medical conditions such as heart disease and failure, stroke, diabetes, atrial fibrillation, depression. The general population prevalence rate of OSA is 17 to 20% for women and 34 to 50% for men. However, there's an increased risk with age and increased weight gain. The literature shows us that living regionally or rurally is related to an increased risk of OSA symptomology and undiagnosed OSA. However, there is very limited data regarding the prevalence of OSA in Australia, particularly regional and remote communities. So this slide uses the upstream and downstream approach from public health to look at the effects of poor OSA management at all stakeholder levels. So looking upstream, at the individual level, poor OSA management can lead to those increased risk of comorbidities as mentioned before. And looking at the community level, OSA can lead to an increased risk of motor vehicle accidents and occupational injury. Looking at the downstream level, we can see how poorly managed OSA at the individual and community levels can increase costs for health services and for the Australian population. So the Australian health expenditure for OSA in 2019 to 2020 was 70.73 million, and severe OSA can cost 16,717 per adult for 1 year. And this is because OSA has been shown to be an independent risk factor for readmission within 30 days of discharge and has been linked with longer hospital admissions and increase in hospital mortality. Finally, the cost of OSA in 2019 to 2020 to the Australian population was 13.1 billion. And this includes the cost to the health service, but also includes economic costs such as productivity loss resulting from increased daytime sleepiness. Our first aim of the study was to measure the point prevalence of people at risk of OSA in the population that present to Bendigo Health. Our second aim was to understand the impact that OSA risk has on the number of hospital admissions and comorbidities. And our last aim was to understand the challenges that rural patients face when they're getting a diagnosis for OSA. Our survey was an anonymous survey that could be completed by Bendigo Health inpatients and outpatients over the age of 18. And we looked at several items such as demographic data, comorbidities, commercial driving, pre-existing OSA diagnosis and CPAP use, any challenges that patients experience during their diagnostic process, and the risk of undiagnosed OSA using 2 clinically validated tools, the Berlin Sleep Questionnaire and the Epworth Sleepiness Scale. The 2 clinically validated tools that are also used by Medicare to screen for patients who are at high risk of OSA are the Berlin Sleep Questionnaire, which is a series of questions to look at snoring patterns, excessive sleepiness and fatigue. And if you score positive on this, it means that you're at high risk of sleep apnea. And we also use the Epworth Sleepiness Scale to look at how symptomatic someone is during the day. So a score greater or equal to 11 demonstrates excessive daytime sleepiness. What does daytime sleepiness mean? For example, you might be driving in your car and you stop at a traffic light and you start to snooze. Or you may be sitting on the couch after lunch and you start to feel a little bit sleepy. So these are examples of excessive daytime sleepiness. Using the Berlin Sleep Questionnaire, we were able to split our participants into several groups. So we had a low OSA risk group and we had a high OSA risk group. From the high OSA risk group, we developed a subgroup, which were participants who scored high risk for OSA on the Berlin Sleep Questionnaire, and they scored 11 or greater on the Epworth Sleepiness Scale, so demonstrating excessive daytime sleepiness. Now we get to the really exciting part, which is the results. So looking at our first aim, which was to try to figure out the prevalence rate of people at risk of OSA in the Bendigo health population. So we had a total of 216 participants, and 40.7% of these people scored high risk for OSA, so 88 people. We had 14.8% of participants score as high risk for OSA and were symptomatic. So this was 32 people. This slide looks at the demographic data of our participants. So we had the median age of 67, and we had a good split of male and female participants in the survey. We had 120 patients who were inpatients in the survey, and we had 12 people who had commercial licenses and about 32 people who had a current medical diagnosis of OSA. Now, I really love this slide, and it really speaks to the literature about how there is an increased risk of undiagnosed OSA in regional and rural populations. So out of the people who scored high risk for OSA in our sleep survey, so 88 people, 75% of these people did not have a medical diagnosis of OSA. And out of the 25% who did, only 12.5% were actually using CPAP, so the gold standard treatment for OSA. Now, this table collates our results, and it relates back to that slide where I was talking about the effects of poorly managed OSA on the patient, but also the effects of poorly managed OSA on a health service. So as you can see, the high-risk OSA patients actually made up a greater percentage of people with a higher number of hospital admissions, and we've got a really good graph coming up which demonstrates that visually. And they also had a higher number of comorbidities, such as CKD, COPD, depression, heart disease and or failure, high blood pressure, type 2 diabetes. First, looking at the comorbidities between the low OSA and the high OSA group, we can see that the high OSA risk group in red tend to have a lot more comorbidities. And this graph demonstrates the percentage of the low OSA risk, high OSA risk, and the high OSA risk and symptomatic groups in a range of hospital admissions. So looking at hospital admissions in the last 12 months. So people who said they had 0 or 1 to 2 tended to be in the low OSA risk group, but as you can see, as the hospital admissions go up, so the 3 to 5 or the 6+ group, there's actually a higher percentage of people who scored high risk for OSA in that group. So I think this representation of our data is really great because it looks at what OSA means to our community. So we asked people if they'd ever fallen asleep while driving in the survey, and we had 32 people say yes. Out of the 32 people, we had 65.6% of them score as high risk for OSA, so about 21 people. And we only had about 11 people score low risk for OSA. And again, another slide looking at the effects of OSA on our community. So we asked people who held a commercial license, and we got about 12 people saying they did. And out of the 12, we had 6 of those score as high risk for OSA. So these are the people in red. And out of the 6, we had 3 of them score as high risk for OSA and symptomatic, so scoring greater than 11 on the Epworth Sleepiness Scale. So this means they could be showing excessive signs of daytime sleepiness during work hours. So they could be driving a truck on the road or driving a forklift, and it makes you wonder about the risk of motor vehicle accidents and occupational accidents as well. Finally, our last aim was to look at the obstacles faced by patients who have a doctor diagnosis of OSA and some of the experiences they face during their diagnosis. So out of the 32 people with diagnosed OSA, about 14 of them mentioned that they struggled with the out-of-pocket costs for assessment or treatment, and 12 people mentioned how they experienced long specialist waitlist times. Another 6 people mentioned how they had to travel long distances to see a specialist, and it makes you wonder about the people who have to drive down to Melbourne in a car and potentially could be experiencing these excessive daytime sleepiness effects from their OSA. Out of the 32 people diagnosed with OSA, these were some of the qualitative responses that we got back about the diagnostic process. So a lot of them relate to the cost of CPAP and also to the cost of getting an assessment. And my personal favourite one is the feels like quackery. Finally, to conclude, we've got to the discussion point of the presentation. So our study is one of the first cross-sectional surveys to measure the prevalence of OSA in a regional Australian hospital population. From our survey, we can see that there is a large undiagnosed population living with OSA and therefore living with an increased risk of comorbidities and potentially increasing hospital presentations as well. We can see that there is a significant barrier to access services to diagnose and to treat OSA, whether they be cost-related or location-related. The survey also asked us to consider the impact of undiagnosed OSA on motor vehicle accidents, whether they be private driving or through commercial driving. There is also a need for an accessible local public sleep service for our Loddon Mallee patients. There's currently no public health sleep service to diagnose or to treat OSA. And we would love to see future studies to help confirm the causal relationship between the high OSA risk and comorbidities and to see how it impacts on hospital presentations. And we'd love to see how these results can be applied to other healthcare services as well. Thank you for your time this afternoon, and I hope my presentation hasn't made you snore. I would also like to say a big thank you to the Bendigo Health Nursing staff for assisting with the survey collection. And here is a list of our references that we used during the literature review and to help guide us during this study.
That was really well done and a great presentation.
Yeah.
I think she should be pleased with that. Is there any, yes, hand up already. Who's got the mic? Sloane?
I think they're all here.
Oh, they're all behind. No, Jenny's got it down there.
Thanks for answering questions, Emma. I guess thinking about those commercial drivers who could be at risk on the road, do they have any surveillance looking for sort of underlying OSA disease as a screening program? Do we know anything about that?
No, but one of our the other co-author, Lauren, who works from at La Trobe, has done some work with a commercial company They actually put in video cameras and in the trucks, and quite a terrifying number of people were clearly seen falling asleep whilst driving. It was, she's published or in the process of having that published. And regional rural companies have been, people have been shown to be at a higher risk, probably because of all the associated issues with regional rural, but it's a really big issue. There is increasing recognition within the sort of commercial vehicle companies, but I don't think it's mandated in any terms of screening. But there's work going on in that area.
The microphone to Amy.
Is there any funding at all for CPAP machines and ancillary, equipment?
Minimal. So we have no funded sleep service in Bendigo publicly. We have a small budget each year for CPAP, but not for the infrastructure around that, and we don't have any sleep studies. So we have a very limited access to CPAP for those, essentially for those patients who we cannot discharge from hospital safely without treating their CPAP, without treating their OSA. So we have effectively about 25 CPAP machines a year. So you need to have a healthcare card to access our internal program, or a pension card or a healthcare card, to show that you're financially vulnerable, so that we can try and use our incredibly limited resource to those that most need it. But we don't have a sleep service. There's no public sleep service in the Loddon Mallee currently, so it's all private. Yep. Comes to about $3,000 for a machine. It's about $300 for a mask, and it's about somewhere around $150 for your sleep study. And then there's the ongoing, you can only access it all through a private sleep physician currently because there's no sleep service. So there's all the private sleep physician costs as well. Most of whom actually, a lot of the ones in Bendigo will do it at, with no gap, but well, that's not entirely true. There's some people that do it with no gap in Bendigo, but there's very, very limited access, and that is a huge problem. I've had a business case since 2011 for a sleep service in Bendigo. Carmel. So this is the first study that we've seen in this sort of environment. But yes, there are similarly, there's sort of what often it's most of the studies that have been done nationally and internationally look at particular cohorts like patients post-operative complications and the risk of OSA in that cohort, or people who have MET calls and the risk in that group, and that's all consistent with this sort of data, yes. So please, support a sleep service.
I think it sounds like this is a great pilot study perhaps, and we need to do some further research to get that robust evidence to support business case. Thank you very much, Emma and Jude. Next up, it gives me great pleasure to welcome to the podium Dr. Bron Brown. Bron's an intensive care senior registrar who's passionate about delivering exceptional care to our most critically ill patients through direct care, clinician support, training and mentorship. Welcome, Bron.
Hello. Hi everyone, thanks for coming. This project is a couple of years old now, and between working full-time took a bit of time to get sorted. But over the years, we were interested to know what happens to the people that we say no to when they get referred to ICU. And so we came up with CReSt. And thank you to Julie, Kevin and Jason Fletcher for being my co-authors. They did all the work, really. And to reiterate, ICU beds, we know here in Bendigo we've only got a finite number of beds, and we get lots and lots of referrals. So we get them from ED, we get them from the operating theatre, we get them from the wards, from Met calls, we even get them from external hospitals. And we can't always fit all of them in, and rightly so. There are some who actually are safe enough to be managed on the ward and don't need to come to see us. The literature that does exist about ICU referrals and the people that are declined and sent to the ward instead is quite scant, and they focus on very particular populations, generally the really elderly patients, and that will be reflected in some of the stats that I show you later. Whenever we get an ICU referral, there's a lot of work involved. The person making the referral has to take the time to ring us, talk about the patient, decide whether or not they need to refer in the first place. And then as an ICU reg, we go and see the patient. We read all of their notes. We have a talk to them, we examine them, we look at their blood test results, we look at their imaging, we determine whether or not they're sick enough to need to come to ICU or whether they can be safely managed on the ward. We then talk to the boss and the boss says yay or nay. If we say no, sometimes people get a bit annoyed about it and they're like, well, you definitely need to take them to ICU, they can't go to the ward. And you can get some discontent amongst the referrals. And that was another reason that we would like to do this study, to reassure and to support our colleagues to know that those patients are safe on the ward. So are our decision-making processes safe and are they clinically appropriate? This is just a quick flowchart of what I've just told you. But in essence, there's no formal structure. There's no formal process. There's no forms to fill out. There's nothing like that when someone wants to make a referral to ICU. The doctor, even nurses on occasions, will ring ICU and say, I think this patient needs to come to ICU, they're pretty sick. When we say no, it's for a reason. And these are the main 4 reasons that we say no. First of all, we don't have a bed. The patient might need to come, and we would normally say yes, but we don't have a bed. Another time, the patient needs to go to a tertiary centre, so it might be that it's a paediatric patient that needs to go to the Royal Children's, or it's a trauma patient who needs to go to a trauma centre. The ones that we're focusing on in this project is those who are too well and don't need to come to ICU, and those who are too sick and are probably going to die anyway. So the study design itself, what we did was we looked at all of the data that we had for the last 5 years, as I said, a couple of years old now, and we were able to work out which patients we said no to because they were too sick, which patients were too well, which patients had no beds, which ones were transferred out, and we dissected that data and excluded the people who were outside of the too well, too sick component, as well as those who didn't have enough documentation to be able to figure out what was going on. So this included the patient's UR number, their age, their date of hospital admission, discharge, date of death was quite important, when they were referred to ICU and why, and then why we said no. A statistical analysis was done that's way above my capabilities, so thank you, Kevin. And I'm not even going to bother trying to explain how it was done. So thank you. Definitions, and this is what was important to us and what is going to be part of what we take forward in the future for education of staff. Patients who are defined as too well for ICU are not necessarily well patients within themselves. They are simply the patients who did not need an ICU intervention at that moment. So ICU interventions are quite specific, and it might be that they've come in and they needed it initially, but they've been treated appropriately in the emergency department and no longer need intervention. We hypothesised that these patients would continue through their hospital admission and their hospital journey without needing to come to ICU in the first 48 hours, and then should be able to be discharged home alive. So we analysed whether or not these patients needed an ICU admission in the first 48 hours, surmising that if they did, it's most probably because something is still going on from their initial admission. So they haven't developed something completely new and different. It's because they are still sick and they are not getting better. We also looked at how the mortality rates were for 48 hours, 28 days and 6 months. And that's part of working out where our decision-making process is safe. Talking about those who are too sick, these are the patients that we see, that we look at, and we look at them and think, this patient is at the end of their life. It doesn't matter whether I take them to ICU and I intervene, this patient is still at the end of their life and they're going to die. These patients would probably be harmed by an ICU intervention, and the focus should be on comfort care, ward-based interventions, and not intervening further for things that are not beneficial. We looked at the mortality for these patients for the same timeframes, 48 hours, 28 days and 6 months. And our results, we worked out that based on age and gender, our mean age was 63.5 years old, and we had 54.9% of patients that were male versus female. And of the refusal numbers that we had overall about 2,500 referrals, with about 2,200 that were accepted, but, 1,200 that was accepted, but 1,542 were refused, and they're the people that we divided into too well and too sick. So 149 people were too sick that we expected to die, and 1,393 were too well and were sent to the ward. Interestingly, we at Bendigo Health take patients of all ages. We can get referrals for 5-day-old babies versus 105-year-old patients. And we could see that it didn't make any difference statistically if it was a child, but being an elderly patient did have some influence statistically. And then we broke it down into our categories, our DRGs, of which organ system was affected, because each organ system that is affected will have a different ICU intervention associated with that. So someone with renal failure or neurological failure will have different therapies. The most common referral was for respiratory support or for trauma. And interestingly enough, on retrospective analysis of that data, they were often intertwined, and it was for respiratory support in a patient with chest wall trauma. And the blunt chest wall trauma pathway is something that had a lot of work go into it that was interesting to see this association. Referral time of day, we often wondered, was that a contributing factor? It turns out it doesn't actually make much difference. We get a lot more referrals later in the day, but statistically doesn't affect anything. And most of our referrals, you can see there, 1,482 come from the emergency department. 1,110, but 1,400. Emergency means it's an on-the-spot referral in an emergency. It's not a pre-planned admission like the elective surgeries that are on the screen. These are the important numbers. Of the patients that we refused, only 2% were admitted to ICU at the 48-hour mark. How many minutes is that? Oh, so, okay, I'm nearly done. 48 hours, so only 2%. So very minimal patients. So 31 patients out of 1,500 come to ICU within the first 48 hours. So we're pretty safe. There's not much getting missed. And there's lots of different reasons that people come to ICU 48 hours later. It might be that they have gotten sicker, or it might be that there's political reasons, or there's no beds on the ward and we end up just taking them for bed purposes. There's lots and lots of different reasons. But in terms of mortality, Of the people that are too well, we're really safe. Only 7 people out of 1,400 actually died within 48 hours, and we don't know whether that's related to them being unwell in general with their general comorbidities in the first place, or whether it's a completely different random situation. And of those that died that were too sick, predicting death's really difficult, but by the time a month went by, a lot of them had passed away. At the 6-month mark, only 30% were still alive. So it still proves that we can't predict death accurately, but we're pretty spot on with quite a few of the people who were dying rather rapidly. This is on our poster. We can have a quick look, but you can see that the bottom curve is the survival probability drops off quite rapidly if you're considered too sick rather than too well. The curve at the top, you've got a pretty good survival possibility if we think you're too well. We can skip over this, but in essence, there's really no studies in the literature about people who are too well, especially young people less than 70 years old. And so this was the first study of its kind in Australia. And those over 75 who are too sick, they've got interesting mortality rates of 33 to 100%. It depends on which study you look at. The refusal rate in our hospital is quite high, and we've found that there's lots of reasons for that. Some are too well, some are too sick. Some of them have already got advanced care directives that say, please don't send me to ICU, but they're getting referred anyway. And so this is something that needs to be incorporated into future education. And there's a lot of people who are getting referred who have very poor baseline function and very terrible comorbidities, who would actually have detrimental effects from going to ICU. And that's the challenging cohort of patients that we need more research about. As I said, these are the things that make us say no a lot of the time. Those who are too well, 55 to 65% mortality in the literature. It's really hard to interpret because they also give no detail about what they died from. Mentioned that one already. And it's really just about changing the referral process. Do they have an advanced care directive? What organ support do they need? If you can't answer both of those questions in an appropriate fashion, then they probably don't need to have an ICU referral in the first place. And so what you can do is you can improve the process moving forward to go to the ward with a good plan for if they deteriorate and start to need organ support, get ICU involved. If they want to have further discussions about their advanced care directive or about what's best for them and their interventions, that's a good time to have it. And we in ICU, we're going to improve our refusal documentation to work out why did we say they were too sick and why did we say they were too well, and get some more information about this challenging cohort that have lots of comorbidities so we can educate and support our colleagues more. And that's it. Sorry, I went a bit long. Any questions?
Questions?
I was just wondering, with the data that you've got, whether you've actually broken it down to what, especially with the two wells, what areas refer more with the two wells, and whether you actually look at, within those areas, staffing, especially nursing staffing, how junior the staff were, how well trained the staff were.
We wanted to, but we didn't have enough specific data, and we also were concerned ethically that it might show prejudices between different decision makers. So we left that part alone. But it would be very interesting to know.
Thanks for your talk. In terms of those patients who did end up needing ICU support within that further 48 hours, has there been any analysis to sort of features in those patients that could have prevented the need for re-referral and, you know, may have triggered a need to originally accept the patient?
We'd need to dissect the data a lot more, and that's in the sense that we need to work out whether they were political reasons or clinical deterioration, and that would involve actually looking through the patient's individual care record and getting personal opinions about why they were referred at certain stages. There's a partial analysis that could be done, but it's a bit more in-depth than what we were doing at that time. Yeah. But I'd like to know too.
What is the lowest hanging fruit here at Bendigo Health to try and bring down our refusal rate?
The lowest hanging fruit here at Bendigo Health for refusal rate, as I alluded to before, I think the blunt chest wall trauma pathway could be tweaked slightly because that's a lot of refusals. I think one of the things that has actually helped in recent years was the establishment of our respiratory department and being able to take some non-invasive ventilation on the wards. I would be very interested to look at the data now, once that's been established, to see how much of those respiratory referrals have dropped off, because that was a big part of our previous workload. Yep. So
Ron, do you
thank you,
think
respiratory.
that would also be beneficial if there were more complex care beds?
100%, yes. We need more complex care beds. Yep, both surgical and medical. Yep, and it would also be quite helpful if telemetry could be performed on the wards for paediatric patients. Yep.
I know on the flip side of it with the surgery referrals that there's been work with the introduction and with Julie's help on that too with Anzella and the using the NILA score and having those conversations prior to the complex surgeries. I think your data is a bit before that as well. So I think that would also probably, if you did it again now as well, I think you'd find a shift there as well.
Yeah, that would be interesting to look at too. We looked in the literature about scoring systems and whether they can assist with ICU referrals or not, but it makes absolutely no difference.
Yeah. I think Jason did a talk on it last year and had a poster last year and presented on. It didn't make a difference to the planned, but it made a difference to the unplanned.
Yep, absolutely. Thank you.
All right, thank you very much, Bron. Great work and some terrific areas of improvement to follow up on there. So next up we have Dr. Hannah Corcoran, who is the Senior Registrar for Paediatrics here at Bendigo Health. She's in her final months of training at last before becoming a general paediatrician, and alongside Kate Sloan and Dr. Joel Ziffer, Hannah's part of the Bendigo Health satellite side of the Airoplane trial, which I will let you tell them all about. Welcome, Hannah.
Thank you. Actually just got a letter the other day saying I've finished my paediatric training after 10 years, so I can now update that bio. Yeah. So yeah, at the moment I'm still, though, the Senior Registrar in Paediatrics, and thanks for the opportunity to come and talk about the Airoplane trial, which is an ongoing trial at Bendigo Health at the moment, so we don't have outcome data for it yet, but it's a super interesting trial that might change neonatal resuscitation Australia-wide, potentially. And just to throw back to Jason Kerr, who did the lovely welcome to country this morning, he says that young people are our future, and this study looks at the youngest of the young, the preterm babies at birth in the first 3 minutes of life, so it's at the very start of life. And the whole gist of this trial is oxygen in resuscitation of preterm babies, because at the moment we know that preterm babies often need help with their breathing at birth, and we still don't know how much oxygen to give them. So it's a big question in neonatology, and they call it the most contentious topic in modern neonatology at the moment. So the Airoplane trial is to determine in moderate to late preterm infants, which is your 32 to 35 plus 6 weeks gestation, who require respiratory support at birth, does starting in resuscitation in 30% oxygen compared to room air reduce the need for ongoing respiratory support. Just for those who don't work in prematurity all the time, a term pregnancy is considered 37 weeks, or 37 to 40 weeks. If you're over 40 weeks, you're post-term, and so prematurity is anything under 37 weeks, but we break prematurity down even further. So under 28 weeks is considered extreme prematurity, and then there's the very preterm, 28 to 32 weeks, and then there's the moderate or late to preterms, which is the 32 to 36 weeks that we're interested in at the moment. So why are we studying preterm infants and why particularly the late preterm ones? Most neonatal research looks at extremely premature infants less than 28 weeks or term infants, so the ones that have made it to full term, and very little of the research looks at late preterm infants, so the 32 to 36 week infants. But there's still a large number of preterm births in that category, so the majority of preterm births are those late pretermers. And preterm births are actually increasing in Australia and across the world. And we know that late preterm infants, so the 32 to 36 weeks, are still a vulnerable cohort. They have worse long-term outcomes cognitively, emotionally, developmentally, but very few of them get long-term follow-up, and as I said, they're understudied. So this is thinking about how much oxygen we use at the birth of an infant regarding neonatal resuscitation. There's consensus that if you're a term baby, so 37 weeks and above, we just start with air, so 21% oxygen, and that most of the extreme prems, so those under 28 weeks, would probably need some oxygen, but in the middle, these late pretermers that no one's studying very much, we don't know whether we should use 21 or 30% oxygen or sometimes even more than that. The reason to study oxygen in preterm babies is because we initially thought oxygen is a good thing, it helps everyone, but we now know that oxygen can be harmful, and that's through the mechanism of oxidative stress, free radicals, and preterm babies are at higher risk of damage from these free radicals, which can damage important organs like the lungs, brain, and the eyes. And premature infants are already at risk of having damage to those organs, and so the oxygen on top of that would increase their damage, which affects them lifelong, because those are vital organs, obviously. And we currently don't have any consensus, as I said, about what oxygen we should use. Even the international guidelines don't agree. So the ILCOR is the International Liaison Committee on Resuscitation, and they release annual guidelines on resuscitation each year. And they say for the term infants, do the 21% oxygen, but for the pretermers, you should choose anywhere between 21 and 30% oxygen. Europe decided to disagree on that, and they said that they definitely use 30% in the extremely prems, and then in the middle you can kind of choose. And this pie graph just is a study of Victorian hospitals, so 20 hospitals, and even the hospitals in Victoria don't agree. So the blue half is half the hospitals said for the late pretermers that we're targeting, they would use 21%. The yellow quarter said, oh, we would use 30%, and the green quarter said is up to the clinician. So nobody in Australia, in Victoria, or across the world is agreeing. So that's where the Airoplane trial comes in. It's always handy when your title, you form it into an acronym, so that's what those underlined letters are, which spell out Airoplane. So it's an unblinded multi-centre trial, so and cluster randomised crossover trial. Unblinded as in the clinicians know how much oxygen the baby is getting, because we need to know that. Multi-centre, it's up to 29 sites now across Victoria and New South Wales. Cluster randomised, so it's randomised by hospital to either 21 or 30% oxygen. And the aim is to evaluate the effect of commencing respiratory support at birth in the preterm 32 to 35 plus 6 week gestation to either 30 or 21% oxygen. And the main outcome we're interested in is whether it reduces the rate of respiratory support required for that baby after their initial resuscitation. And there's some secondary outcomes as well. So any baby born preterm between 32 to 35 plus 6 weeks gestation in any Victorian or New South Wales hospital who's part of the trial is included in the study, and essentially all those babies' data is collected, but the only ones included in the outcomes will be those who received respiratory support in the first 3 minutes of life. So respiratory support meaning CPAP or IPPV, so we're helping the baby breathe directly after birth. And exclusion criteria is any major anomalies essentially, or their baby is receiving palliative care from birth. The sample size is 1,200 infants, which was calculated to find an 8% reduction in the need for respiratory support. And yeah, that's the main thing to say about that. So these are all the sites involved. You can see there's a lot of metro hospitals. There's some across Victoria and New South Wales. Bendigo is a site, and we're a site here because our special care nursery takes babies from 32 weeks, so it's kind of a target population for us. And it's being gradually rolled out at different times to different hospitals. So we've been going since May 2023. I'll skip over that. Oh, I should just say about consent. The consent for it is waived, which was picked up interestingly early on in the media as a kind of controversial topic. But as I said at the start, we don't really know which is better out of air or 30% oxygen. And we think it is a low risk intervention for the babies, and it's already clinical care that we're doing. We're basing it on clinicians' decisions to do either the air or 30%. So what actually happens with the study? Well, each site, as in each hospital, is randomised to either the 30% or the air. And the clinicians know that when they go to the birth of a baby, so at preterm births, there's a paediatric doctor present, and they set up the oxygen based on whichever arm they're in, and then they provide usual resuscitation as they would based on the need of the baby. And then as they've stabilised the baby, the doctors involved collect that data at that point in time, and then the baby goes on to be cared for either on the women's ward or special care nursery usually, and then when the baby is discharged home, some more data is collected about their clinical stay. So this type of data collected at birth is kind of about the birth, how much respiratory support was needed, how much oxygen was needed, and then at the time of discharge of the baby is kind of how much respiratory support they needed through their stay when it was stopped. So as I said, we've been going at Bendigo since May 2023. We were randomised to the intervention arm, which is 30% oxygen to start with, and for half of our recruitment period we run with 30%, and there'll be other hospitals that are randomised to just air, and then we have a crossover. So this just kind of explains the treatment pathway that the clinicians follow, which looks complicated, but it's basically that if the baby needs help with their breathing and we're in this treatment arm, we start with 30% oxygen and we do 30% for the first 3 minutes of life, and then we do care as usual. There are some caveats that if the baby needs to be intubated or you're doing CPR, you can change the oxygen, but outside that you shouldn't change the oxygen requirement. And then in July of this year we swapped over, so we're back to the control arm, which is air, and we continue for the rest of our recruitment period, and that's just the control pathway. I might skip over that. Where we're up to, as I said, there's many sites involved, and so far 920 infants have been recruited of that target 1,200 sample size. And Bendigo Health, we've recruited 80 so far, and 21 of those have needed respiratory support. The rate of respiratory support requirement has been similar to a similar time period previously at Bendigo Health. Later this year, there's been less preterm births than prior years for a reason we don't yet know. So just to talk about some of the challenges of being a regional site that's involved in a multi-centre trial. As with most regional sites, the issue is often workload, so we don't have any clinicians who are funded for research, so we do a lot of this work on top of our usual work, and we have a lot of rotating doctors in paediatrics, so we have 32 junior doctors who rotate through the year, and they all need to be trained up on how to do the data collection and about the trial. And yeah, so it's kind of those challenges in keeping everyone up to date and on the same page. But increasing the visibility of the study is a target for us, so we've made this little leaderboard because we know that in paediatrics everyone loves a colourful sticker, even people over the age of 18. So people who, clinicians who are involved, when they enter the data they get a sticker, and then you get prizes based on numbers of stickers, and quarterly there's a bigger prize for the winner of that term. We've just got a little Airoplane research notice board in our doctor office, and on all our resuscitators is lots of information about what oxygen you should be doing and how to run the pathway. Some of the benefits for our site of being involved in this trial is that it's a pretty significant trial for neonatal resuscitation, so we're pleased that our population is involved in the study. As we know, throughout this week we've learnt that regional and rural patients are underrepresented in trials, so it's great to have our population sample represented. it's important to study these late preterm infants who are also underrepresented, and the outcomes of this trial might change what we do, not just here, but probably Australia-wide. It's also been great to collaborate across centres, so we collaborate with the neonatologists at MCRI and the tertiary NICUs, who we learn from, and collaboration between the clinicians and researchers has also been really good as well, and a good focus for our team to focus more on resuscitation and learn about it. So yeah, that's basically the Airoplane trial. We're trying to figure out, is 21% oxygen or 30% oxygen for late preterm infants better? And the recruitment's going pretty well, and we're excited to find out the results. And thanks to everyone who's been involved in this study. Joel Ziffer is the site investigator, and to Kate and Sloan, who've been a big help through the study. Thank you.
Questions? Amy?
That was excellent. How long is follow-up after they're discharged, and is that just your standard care follow-up, or is there some way of informing patients and, well, families that they're involved in the study, or is it just...
Yeah, it's a great question with the waived consent. So there's information posters around special care and the birthing areas of the hospital, and there's also brochures available. And when people are enrolled in the trial, they get given a brochure. The progress of the study at the moment gets sent out through a monthly newsletter, so all the people involved in the research know how the project is going, but there isn't yet a channel that it's fed back to the people recruited to the study. I'm not sure how that's going to be communicated to the people eventually. Is it? No. And what's the other question? How long is follow-up? So, yeah, I was just focusing on the kind of primary outcome today, which is the respiratory support duration needed. So the end point of that data collection is the inpatient stay and kind of what happened as an inpatient. There is a kind of collateral data follow-up with the Gen V study, which is recruiting, it's a big study to talk about, but aiming to recruit every infant born in Victoria and track them for a number of years. And so they're hoping to use some of that long-term developmental outcome data to compare back to the oxygen from when those babies were born.
And just to add on the waiver of consent, when that came out in the news, the MCRI formed a focus group of mothers who had given, families who had given birth, and had a huge, they all came together and discussed, you know, would you like to know, and how do you want to be informed, and things like that. And you know, the consumers said, yeah, we're in a point where we want you to save our child, and that you're going to intervene anyway. And as a group, they all came together and, you know, formed the plan that it is, which is giving them a leaflet and et cetera, and, you know, that went back to ethics and everything and all that kind of stuff, so.
Yeah, like the discharge data is entered again by the doctors involved in the resuscitation, but there is, it's compared to just normally collected hospital data on neonatal outcomes, which is through our birth operating system, BOSS, we call it.
Thank you very much, Hannah. Now I'd like to introduce Dr. Matthew Bricknell, who is a current BPT2, I'll have to get that explained to me, with a passion for respiratory medicine. Matt rotated as the Bendigo Respiratory Registrar in early 2024. You've previously published research in the post-op complications in lung cancer and new therapies for chronic cough, and you hope to become a respiratory physician and an active member of TSANS. Well, these acronyms I'm not aware of, but welcome to the podium, Matt. Thank you. What is BPT2?
Basic position training for classic doctors using their lingo. Hi everyone, I'm Matt. I come up from Melbourne today. I'm driving in the horrible rain and almost veering off the road, which is always a bit of fun. But I'm presenting today just on an audit that myself, also Emma Broadfield, and some of our other colleagues at Bendigo undertook when I was here as one of the members of the respiratory team earlier this year. So, providing a bit of background, first of all, what is a pulmonary embolus, or pulmonary emboli as a plural? Essentially, these are clots that exist within the lung arteries. They're common in an ED population. They're very treatable, but they can be life-threatening if they're not enacted upon quickly. So to think about how exactly they are diagnosed and investigated for, they're usually investigated via a CTPA, or what's called a CT pulmonary angiogram, where we inject contrast into the body and then that will light up the lung arteries to see if we can find clots within the lungs. This is an investigation that's not without risks. Firstly, providing a contrast load to someone can induce some kidney damage. Additionally, it's also quite a high load of radiation that we're providing to someone. So we want to be pretty sure about the diagnosis before we go throwing this test at someone. The other thing to consider about CTPAs as well is that they're quite expensive and burdensome for patients. So there's obviously downsides to performing that test. So it's always important to think about what are some things we should be considering before we order a CTPA in patients who we're suspecting may have a pulmonary embolus. So oftentimes, as clinicians, we always go to flow charts because it makes our decision-making a lot easier. One of the most common tools that we have at our disposal for clarifying whether we want to do further investigations to investigate for PE is what's called a Wells score. And this uses a number of clinical data such as is the patient tachycardic, has a fast heart rate, do they have a history of cancer? And that gives us a risk assessment tool to see how sure we are about whether the patient does have a PE. There's quite a significant difference between low to medium to high risk, with a score of low, meaning in an ED population is about a 1.4% occurrence of PEs, moderate risk about 14%, and then high risk about 40% of patients will have a PE. And then there's further algorithm down that pipeline, but you can see the endpoint there to investigate is in a CTPA, or an alternative is something called a VQ scan as well. And those are just some of the criteria that are used as part of some of those algorithms. So why do we use it? It's quite sensitive and specific. And VQ, which is our alternative modality, is also quite good, but it also depends on how likely, how confident the radiologist is at reporting it. I tend to find that radiologists seem to be more confident in reporting the CTPAs as positive for a PE. And then there's another test that's used in the algorithm, which is D-dimer, but we won't touch on that too specifically. So what do we do in this audit? Well, firstly, we looked at the Bendigo medical imaging database. The population we were interested in was patients at Bendigo Health in the inpatient, ED and outpatient setting between the start of this year and the end of February. We looked at those who are undergoing a CTPA, and the thing we were most interested in is the incidence of PEs amongst those patients. Some other things that were relevant because of the algorithms that we often use is whether these patients had a chest X-ray prior to having this scan, because some of the pathologies that you can see on a CTPA can simply be investigated via a chest X-ray. Other things were the amount of Wells scores calculated, because obviously that's an important part of the algorithm, how many D-dimers were calculated, and other diagnoses that were found on CTPA that could be an alternate explanation for the patient's presentation. And we excluded duplicate scans. So in terms of our demographic data, the mean age here was about 63 years old with a proportional approximate gender split. Most of these scans were obviously in the ED department where time is of the essence. Secondly, most in the inpatient setting. In terms of those who received a chest X-ray beforehand, quite a significant proportion did, about 60%. And, these tests are often quicker to facilitate in the emergency department as well. About 33% of patients received a D-dimer previous to a CTPA, which is a simple blood test. And we saw that about in the 30% of people were calculating a Wells score prior to ordering a CTPA, which is one of the first steps of that diagnostic algorithm. The key statistic, obviously, we were interested in was how many of those were positive for a PE that went through the CT scanner. And we found about 10.7% of those were. So how do we compare that? And is that a good or a bad number? We'll talk about that soon. Oops, sorry, I think I just skipped one there. Here we also have some of the other pathologies that were found on the CTPA if a pulmonary embolism wasn't found. Obviously the first one being nothing else was found, but some of the other significant diagnoses were atelectasis and also pneumonia, which can both be simply investigated by a chest X-ray. So the key things to note from this study, this audit, is that 35% of clinicians calculated a Wells score when we want really 100% to be doing so. It's difficult to interpret exactly what the rate is because we were using whether the clinician actually reported it in documentation and that it was clearly actually assessed. We do have a program here in the electronic patient medical record system where you have to enter that data point, but it's a binary system, greater than 6 or less than 6. So we didn't take just filling that out as part of the clinician actively calculating their Wells score. Like I just said, a binary system is a limitation because it doesn't allow the clinician to accurately document what their score they calculated was, and it tends to lead clinicians to have a propensity for overcorrecting in order to facilitate that scan. And the third, that 10.7% of CTPAs were positive for PEs in this population. Compared to other audits, when we take out audits that have a very small amount of patients or that don't have comparable patient cohort, we sort of see that the aim tends to be around 12 to 17% of what the incidents we're aiming for, so we were a little bit underperforming here in terms of our hit rate. In terms of how other centres in the past have corrected deficiencies in the incidence of PEs on CTPA, there's often the use of clinical decision support frameworks. And this was a study, I believe, out of America, which looked at prior to and post the implementation of that support framework. And what they found was that the incidence of PEs on CTPAs improved by 6.6% once that system was implemented. That included senior physicians looking over the shoulder of juniors who were ordering these scans and double checking that it was for the right indication, that it was meeting their diagnostic flowchart. So what can we learn from this audit? Firstly, that we need to further educate physicians on how to appropriately order CTPAs and work through that pulmonary embolism workup to make sure we're not skipping steps and causing patients unnecessary harm via scans. Secondly, possibly we could further explore improving the EPR to allow clinicians to report the individual number of the Wells score rather than just a greater than or less than number. And also, if they fall below that criteria in the high-risk group, forcing them down the other tests before that test can then be ordered. And the third is just, this is a challenging diagnosis. Even people that do have a low-risk Wells score can still have a PE. And the second thing is that this is a diagnosis which is often time-sensitive and can kill quickly if it is large, and treatment can be implemented quickly if the diagnosis is found early. So my key message here, if there is suspicion of a PE, the Wells score is really where everything starts, and that's something that we need to improve in here as clinicians. Those are the references that I used, and thanks for listening.
Any questions?
I was curious, for the inpatients, is using the Wells score validated, or is it just for outpatients? And if it's not that well validated, how can you better risk stratify inpatients?
Yeah, it's a really good question. Certainly it isn't validated in that inpatient setting, and I guess at this moment we don't really have another good validated tool to use, so it's often a fallback option for clinicians. Usually that we would prioritise sort of clinical gestalt in that setting for inpatients, but this is something else that we still have at our disposal, even if it isn't necessarily validated in that population. Yeah, about 70% of them were, yeah.
Other questions? We will thank you again very much, Matt, and thank you. taller than me. We'll just lower that again. So, and I'll just let you know now that this is actually the final session of the day. You were second final, but we've had Felicity is unable to attend, so we will have a chance to listen to her again. So we're going to welcome Lucy Rodder to the podium, and Lucy is an occupational therapist with 20 years of experience working in public health. You look so young. She has worked within specialist palliative care services for 7 years, has a passion for providing high quality palliative care to enhance the quality of life for patients in our region. Welcome, Lucy.
Lucky last. So this cross-sectional study is one that we did across the Loddon Mallee region, and another shout out to Dr. Steve Barrett, because he put in a lot of work to pulling this together as well. So a bit of background about this study. In late 2022, an allied health lead role was introduced to the Loddon Mallee Regional Specialist Palliative Care Consultancy Service. And a component of this role is about providing support and education to allied health professionals in our region that are either providing palliative care or that support patients with terminal illness, and sort of embedding that palliative approach to their care. It's really well documented in literature that this group of professionals can play a beneficial role in addressing what can be really complex needs from a physical, cognitive, psychosocial and spiritual approach. And addressing these is a really integral part of palliative care and can have implications for the quality of life for the patient, but also the well-being for carers and families, and also have a flow-on effect for health services. For example, being able to support coordinated discharges for patients and also prevent unnecessary hospital admissions. So in the early stages of this role, there were some really glaringly obvious things that we needed to consider. The Loddon Mallee is obviously a really big region, and in that region we've got about 500 to 600 allied health professionals working in public or community health. And they're all of many, many different disciplines that do different roles across the services. There's very few allied health professionals working within specialist palliative care or palliative care services. So patients are mostly receiving care through other non-palliative care specific services, so outpatient rehabilitation, ward-based services and community health, for example. So this sort of led to the questions of how do we tackle this task of increasing allied health professionals' knowledge and to be able to make sustainable change for our practice, for our families and patients. And is this actually a need, or is it just an assumed need that we've come up with? There's minimal research identifying the learning needs of allied health professionals with regards to palliative care, and there's an even bigger gap when we're looking at regional and rural practice, and especially for clinicians that are working beyond palliative care services. What we do know from other research is that many allied health professionals didn't feel like their undergraduate studies equipped them to be able to meet the needs of palliative care patients, and those working outside of specialist palliative care services were far more likely to be overwhelmed by patients' needs at end of life, which reflects pretty well the workforce in our region. Additional education in palliative care did translate into increased confidence in practice. So with that, the aims of the study really was to look at how often allied health professionals were providing care to patients in our region in the last 12 months of their life. What was their confidence and skill level when working with patients, providing components of palliative care or specific interventions that would support palliative care? What education has already been undertaken by these professionals, and what are the barriers that have prevented people from accessing them? So from establishing the need, I engaged the help of Steve through the Allied Health Research Knowledge Translation Lead, which has been absolutely invaluable in making this happen. We developed a 31-question survey that was informed by the National Palliative Care Guidelines, prior research, and also focusing on some of the symptoms that we use commonly in standardised assessment tools in palliative care across the country. We used online software for self-reporting and explored patient self-reported skill and confidence, providing the components of palliative care and specific interventions, and they were measured with a 5-point Likert scale and a 1 to 10 numerical scale. We had other multi-choice questions and free text questions that gathered information around the demographic data, disciplines, service areas, levels of experience, the frequency of care that was provided, as well as exploring some of those educational needs and barriers to accessing education. The survey was pilot tested before distribution with a variety of clinicians to ensure relevance to practice, especially when we're considering so many different service areas and so many different disciplines. It was then distributed via the Loddon Mallee Allied Health Leadership Group with reminder emails at a 2 and 4 week point, and was open for 6 weeks in total. So of the respondents, we had 121 people respond to the survey, and that represented 11 different disciplines and 15 different health services. Inpatient hospitals, community allied health services, and outpatient rehab services were the most represented services, but also palliative care, residential care, transition care, mental health and chronic disease management services were represented, which was really fantastic because I think we all know that people don't have just one health issue happening. They don't operate in silos, and people are going to have intersections with the health services at many different points. Over 40% of clinicians were seeing people with terminal illness that could die within 12 months, either daily or weekly, and 72% reported they were doing this monthly or more frequently. So what did we find out from them about their skill and confidence? Really, there was a higher level of confidence and competence reported with components of care that weren't unique to palliative care, such as supporting patients and families with distressing emotions and grief associated with physical and functional changes, and some of the interventions like fatigue management. However, overall, the confidence levels still were not overly high, even with some of those symptom management ones that rated more highly, such as fatigue management and breathlessness. The median score for that was still only a 6 out of 10. Lower levels of confidence were by far reported in components that were specific more to death, dying, and some of those symptoms that we really commonly see as people are deteriorating. And there was certainly, when we broke it up to look at the different groups, comparing it with the overall population, those that were providing the care more frequently were reporting higher levels of confidence and competence, which you'd hope for, and not unexpected. And those that had done education were rating the highest. So that was sort of consistent with other research that had been completed. When we were looking at the education needs, 67% of the respondents hadn't done any further training. When we spoke about this in the survey, it wasn't necessarily formal education we were talking about. This could have involved workshops in services or online self-directed learning. So 16% had done some informal or self-directed learning, and 16% had looked at in-services and formal training. So the education was quite low overall, we would say. I guess when we think about the barriers to people accessing further education about palliative care, one of the things that is probably a silver lining of COVID, I suppose, is more than ever now there's so many readily accessible, online, evidence-based, free education opportunities that we can access as regional clinicians. But by far the highest rating barrier was that people were unsure to access, and that was with 64, and time, which probably wasn't as much of a surprise, at 61 counts. Cost and travel were the next two highest rating barriers, but they were far below the other two. And of the 121 respondents that we had, only 21 people identified that further learning in this area wouldn't be relevant to their learning goals or to their role. We also got some really valuable information about what sort of the preferred methods of learning would be, and workshops and in-services were the clear preference, and that was 30% higher than the second one in line, which was online webinars. And self-directed modules was actually ranked the third highest, which is interesting when there is so many ones available to people now. So I guess what's that's translated into practice. So we know that many allied health professionals are involved in this care, but education rates are fairly low, as are confidence levels, particularly when it comes to those interventions and components of care that are specific to palliative care. So it really does support that need for further education for clinicians. It's been able to give us a really great understanding of what that education needs to be about, and really be able to offer that targeted education to people. So I guess in practice, what's that translated to is being able to offer discipline-specific education across the region, service-specific education, but also education days that are then open to all allied health staff to attend. It's also given a lot of information about what the best structure is, and given me probably that clarity to understand about what other options are out there that we can redirect clinicians towards. And making sure that in all the planning for any education that we're providing, able to address those barriers. And fortunately, with the role that I have, I am able to travel to people and take the cost out of it, which we know are two big barriers, and help navigate for them how they can find other information that's going to be beneficial for them if they want to access further learning. It's also given the knowledge to contribute to strategic change. For example, an allied health, palliative care, novice to expert framework that we've been working on across the state, and being able to make sure that that also reflects the needs of regional clinicians. And also some baseline data for potential reviews in the future if we so choose to do that. And that's the end.
Lisa, just out of interest, how many surveys did you send out? What sort of response rate did you get? Because 121 is a pretty good number.
Yeah, we were very happy with that. We don't actually know the number of allied health professionals specifically, but it's estimated around 500 to 600 in public and community health. That's sort of not considering people that are working in private practice. How many it got to, we can't be too sure, but you'd say at least around 20% response rate. So we're very happy with that.
No, please join me in thanking Lucy. Thank you. Oh, look, I'm sure for those who have been here all day, you're probably like me, exhausted but brain whirring with all these different ideas and strategies and thoughts around what we've heard. You know, I think every presentation today was just, you know, it was all different. It showcased the diverse needs of our community as well as our diverse range of research and innovations that really do address some of those diverse needs. So, you know, it's been a great day, and for our passionate clinician researchers and our academic partners and other health service staff and community members to be present, to hear all about it and support our achievements in research, I think it's been just amazing. Again, I do want to just thank Alan and the team from Trial Docs who sponsored that beautiful catering from Pepper Greens in collaboration with Walters Kluwer, who also provided some sponsorship there and has actually also donated the poster prize, which is an academic book voucher worth around $200. So VCCC, RCCC, our friends from the Alfred, who I know have been here supporting us all day as well, thank you all very much. So I am going to go straight into, so as you know, the posters that were over in the learning space too have been available and provided a point of interest all week at the in the hospital atrium for everyone to go and check them out. We had lots of votes for favourite, the best poster in the atrium, and today we, at morning tea and again at lunchtime, the attendees of the showcase also voted. And if I can get my notes right without everything dropping on the ground, which I can't, so I will. And I'm not sure if the winner of the best poster is here. And I feel like we should do a drum roll or something, but I don't know how. Thank you. The winner of the Best Poster Award at the Research Showcase 2024 is Trauma and Violence Informed Care, Perspectives from Korean Women of Refugee Background. And congratulations to Shadow Tote. And Shadow's not here. She actually presented one of the first sessions after morning tea this morning and was telling me through the day about the horrendous drive from Melbourne that she'd gone through on the way up here. So I think she might have headed off a little bit early to get home before the storm actually went again. So we will follow up with Shadow. Thank you very much to all of the poster presenters. The posters looked fabulous, and it was actually quite a, there was only 3 points of difference. There were 2 that were equal second, and Shadow's that was first. So awesome. We will get that to Shadow. The next award is one that's very close to my heart and probably of the hearts of you here as well. If we can have the next slide. Yep, do I do that? Yep. So it's the Evan Stanier Innovative Health Research Award, and that's the inaugural award. And it's Evan Stanier, many of you will know and remember. He was a long-serving Bendigo Health employee. He was passionate about innovative research that translated into improved health outcomes for people. He commenced at the Bendigo Psych Centre back in the early 80s. He was my boss back then, and after many years of clinical work in a broad range of mental health areas, he moved into the research and innovation space in 2009. His passion for health innovation and research was only equalled by his advocacy for placing the person at the centre of their care. Evan was an inspiration and a mentor to his colleagues. He sadly passed away in July 24 after a brief battle with a very aggressive cancer. So it was an actual honour to create an award to honour Evan and his inspirational mentorship and work in research and innovation over the 40 plus years at Bendigo Health. So this award itself recognises an exceptional innovative research idea that demonstrates originality, impact and potential to improve health outcomes. The winner will receive a $5,000 stipend, which is proudly supported and donated by the Bendigo Health Fundraising and Foundation, and we thank them very much for their support of this. They'll receive mentorship from our team and an opportunity to turn their vision into reality and make a positive impact on people's health and well-being. We put out a call for applications for this prestigious award, and we're thrilled with the quality of the applications received. I'm also incredibly thrilled and honoured that we have Evan's family with us today to be able to present this award. So, pardon me, Brianna and Dylan. So Brianna, Evan's daughter, Dylan, Evan's son, and I know Ben may not be here physically with us, but I know that he will be here in spirit. And I'm sure that he would also be chuffed with the thought of Evan having this award in his honour. So, as I said, we're thrilled with the quality of applications received, and I'd actually love to give each of the applicants an award, but unfortunately we can only give one. I tried to get some more, but apparently I'm not allowed to give one to everyone. It was absolutely outstanding, the quality of the applications. But the winner of the award clearly articulated the issue they are hoping to address, provided evidence of the need, and has proposed an innovative solution that will improve safety and quality of care. The application that has won the award is the use of AI to improve efficiency in clinical documentation in an outpatient hand clinic setting. And congratulations to Susie Ellis, who's an occupational therapist, hand, lymphedema and wound clinics.
Now, clearly I'm an imposter. Susie unfortunately wasn't able to be here. I'm Wendy Miller, I'm the Manager of Outpatient Rehabilitation, and Casey James, who's the stream leader for Hand Clinic. But we're here on Susie's behalf and we are delighted to accept this. Hand Clinic is a really busy clinic, outpatient clinic, and I guess what the clinicians are hoping to do is to find some really clever ways of getting the client documentation into the notes without spending too much time, because it means that they can actually spend more time with clients. So we don't quite know how this is going to look, but we want to have a really good go at checking out what the options are and seeing whether we can actually make a first with this. Fantastic. So thank you so much.
Congratulations.
So yeah, really enjoy it. Yeah, well done. Thank you so much.
Oh, yeah. Oh, one of you first. First, and then I'll... Thank you so very much for that, and really appreciate Libby, Dylan, Brianna and Zoe being here to support this award. And Ben, we are thinking of you, and thank you as well. And I'm sure Susie will be wrapped, as Bendy said. So, what a week, what a day, what a month, what a year really. But Research Week this week I think has proved to be bigger and better than ever. The showcase today I think was just awesome. And of course I must thank my team who have worked tirelessly over the last few months, well, years, but particularly on this for the last few months, and we really appreciate their going above and beyond to make sure that this event ran incredibly smoothly, and I think you'll all agree that it did. And thank you all for coming. Really appreciate your support and interest in research. And I look forward to getting more abstracts next year, having an absolutely full-on program. I'm not sure how we can make it bigger and better than this year, but we will give it a go. And I will thank you all very much and hope to see you again next year.
And just before everyone goes, we've just got a very special thank you for you and all of the team. We know
Honestly,
that
they never do what they're told and they surprise me.
we know that there's a huge amount of work that goes into Research Week, and Ange all year has weekly meetings and is always promoting research and innovation across Bendigo Health and across the Loddon Mallee. And she is what we always say as our wonderful fearless leader. And we're very grateful. We're also, obviously, more recently have Sloane and Kate, who do an incredible job, and the Anges in the library, who also do an amazing job with everyone, especially anyone that needs articles and things looked up. And Jasmine, I don't know if she's here, but people, who also has been doing amazing work in all of the tele trials. So we just wanted to say a huge thank you to you guys. And then we have our wonderful admin staff, so Nat and Tara. And Tara's done a huge amount of work in keeping us on track and keeping us organised and keeping us fed. Both Nat and Tara do a great job at keeping us fed. So we just wanted to say a really special thank you to all of you, but especially they do. So thank you so much, guys.
And I always forget, not last but not least, Joe from Power AV. Can never do it without you,
Yes,
Joe.
thanks, Joe.